Hi, everybody. I hope everyone's having a really good Friday. Today's topic is myopia management in 2020. And for many of the people listening, because we are probably adults, myopia management looks very, very different today than it did when we were all children. So if you are myopic, that means you are nearsighted. You probably wear contacts and glasses, or maybe have had LASIK done. Probably when you were a kid, your prescription changed year after year and you had to constantly use stronger and stronger correction. Today, we have ways to slow that down. And that is what is implied by myopia management. So I'm going to do the best I can to give you all the latest and greatest up-to-date information on the topic of myopia management. Okay, so as I just mentioned, myopia is defined as nearsightedness. It means your natural focal point, or the person who is myopic, the patient, their natural focal point is closer in than distance, closer than 20 feet. They have a minus number in their glasses or contact lenses. So if you're wondering if this applies to you and you happen to have your contact lens box sitting nearby, you can go look at it. And if the number starts with a minus, you are nearsighted or you are myopic. This happens because inside the eye, the light comes to a focus in front of the retina instead of right on the retina. You can be a varying degree of nearsightedness. It just means the light focuses farther in front or closer to the retina in terms of that number. This can happen because in a sense, the eyeball is too long for where the focal point is. What we change when we put in a glasses or a contact lens prescription is we move the way the light is refracted to reach that farther away point. Okay. As far as kids go, a lot of times kids don't necessarily know what blurry is until they've started to use glasses or contacts. So sometimes they're just squinting and that's all that you know about it. Often you will hear that kids are squinting in school or the board is blurry if they're sitting in the back of the classroom. As I mentioned before, as many of us remember times in life when prescriptions got worse and worse after year, or maybe you remember that, every year or so when you'd get the new glasses, those leaves on the trees would just look really, really crisp again. This is because typically when the onset of myopia is younger than 15 years old, it typically does go through that period of time where it gets worse and worse. And as far as why this happens, we don't totally understand the full complexity of it. Part of it is genetic. Part of it seems to be environmental related. And some of it, to be totally honest, seems kind of luck of the draw, a little bit of random nature to this. So about that progression, the worsening of the nearsightedness, the most typical is about 0.5, a half a diopter per year. So if you are nearsighted, you are probably used to looking at these prescriptions that look like a 1.50, they kind of look like a dollar sign. If this is kind of vague to you, then let's just recap the total point, which I will get to in just a second here. So in the patient number 1, they are a minus 1.5 prescription at age 8. They go through a change until they're about 15 of a half a diopter per year. That's the 0.5 number you see. So over time, around age 15, they become a minus 5 as their new prescription. So they started at a minus 1.50, 150. So now they're a minus 5. Patient number 2 was a minus 150, but at onset younger at age 6, and it's progressing a little bit faster, slightly faster rate. So their progression is 3/4 of the diopter, or minus 0.75, again until about age 15 when we know people start to level out, and they're going to reach a prescription of a minus 8.25. So keeping those numbers in mind, this is if they go through the typical sorts of changes, and those two numbers are pretty typical in terms of the amount of change that we see year after year. So myopia management is when we intervene to slow down or halt this progression. And one of the biggest reasons we want to do that is because the more we understand about that change that they're having, we're seeing that it is related to an increase in the actual size of the eye, which stretches the retina. And that retina stretching can lead to some health concerns. So it can lead to making nearsighted people more likely to have things like retinal detachments. You've probably been told, if you or a family member are nearsighted, you've probably been told about looking out for a curtain or shadow-like effect across your vision, a sudden onset of new floaters. Things like that we'd want to see right away because they're signs of those retinal tear or detachment that would make us concerned. The other thing to consider when we mentioned those numbers before, the -5 and the -8.25 patients, they're going to be people who rely on the glasses or contacts full time. They really aren't going to be somebody who's a very part-time wearer who uses them just for occasional use. So they're going to heavily consider LASIK as an adult. We can make sure that people become more likely to be good LASIK candidates if their prescription is on the smaller side. So up at a -8, it kind of can be dependent upon the other factors going on in somebody's eye if they're a candidate for a LASIK type correction. If they have a smaller prescription, they're a better candidate for those procedures. And then on the top of this screen, it says range of clear vision. And what that means is the higher the prescription, the closer to the patient or the person, if that's you, the natural focal point is. So people who are about a -1, if you have your computer that you're watching on right now about an arm's length away from you, a -1 focuses at about that arm's length. Someone who's a -4 can get by doing some reading and some working on a phone and things because it's about, if I turn sideways, it's about this close in to be about a -4. So above that, they're really not, they don't really have any range of clear vision whatsoever. Someone who is a -4 is probably only taking those glasses or contacts off or out for the end of the evening when they're in bed reading at that distance. So preserving that range of clear vision can be really, really helpful in terms of being able to have more freedom from glasses and contact lenses. The health aspect I mentioned is related to several things happening in eyes. Myopic maculopathy is also a type of macular degeneration that happens in people who have a high prescription as opposed to people who are an age-related. Retinal detachments, as I've mentioned, certain types of cataracts, and then glaucoma are more likely. This tells you by what odds ratio someone is more likely. It never becomes more likely that something will happen than something won't happen. But anything we can do to help the health of the eye, we're pretty committed to. So we'll go ahead and talk about how can we intervene? How can we slow that down? So actually get into ways that we can help patients who are nearsighted, help kids who are nearsighted. So one of the biggest things that we recommend for kids who are not yet in glasses or contacts is the role of outdoor play in prevention of onsetting the nearsightedness. Kids who play outside more tend to become myopic later in life than kids who don't. As I mentioned before, there's a genetic factor, there's kind of a luck of the draw factor here too, but this is one way the environment really plays a role. We don't know if it's because you get more work at distance or if it's because of something with UV light. We don't fully understand why, but this does seem to be very reliable and helpful in terms of predicting myopic onset. And so why we care about when it onsets is because, as I showed you in that example, the patient who it onsets younger in typically ends up at a higher prescription once they do eventually stabilize. So if your kids are not in glasses or contacts yet, encouraging outdoor play. The number is about 45 minutes per day is what's been studied, and it does not have to be 45 consecutive minutes. So it's a pretty doable number in terms of getting kids outside. We know that there's benefit to kids once they even do have the glasses and contacts, but it doesn't seem to be as clinically appropriate as it does for those who aren't yet in the glasses or contact lenses. This slide has the things that don't work quite as well, just so that in case you are wondering, would this work? One thing that's been tried is when a child has a small prescription, just not prescribing it to see if that would help slow it down. It doesn't work in any studies that have used that as a method to check. Another glasses option, related option that has been tried are bifocal glasses. It's just mixed results in studies. Part of that is because there are so many different bifocal glasses designs that it can be hard to control for certain ones. So when the other more reliable options that we're going to talk about don't work for a certain patient, or they're just not a candidate for those. These can be considered, but they typically aren't going to have a really exciting amount of slowing from using a pair of bifocal glasses. Okay, here are the 3 ways that we know we can impact that, that change in a positive way. 2 types of contact lenses and 1 eye drop are what we have right now in 2020 to help slow down that change. The first type is a multifocal contact lens. They have to be very specific in design. This isn't every contact lens that works for somebody who's over 40 and needs help at near. They have to carry a very specific design, or they just won't work. There is 1 contact lens that carries the FDA indication for myopia control. The name of that lens is MiSight, and we do have it here at Nittany. The others that I'm going to talk about, this is considered off-label for. The FDA has approved these contacts as a method for vision correction, but not specifically for the use of myopia control. So the multifocal contact lenses, they're the typical soft contact lens that most patients, most parents think about when they think about their kid in contact lenses. So sometimes that's a great option just because family members are familiar and it's easy to wear contacts during the day and then just take them out at night. The orthokeratology is a type of contact lens that's sometimes referred to as ortho-K or OK. It's a hard contact lens, so not the same as the flimsy flip inside out material that most patients and parents are familiar with. This is kind of an old style. If someone had contact lenses years and years ago, they may have been using what we call a GP or a hard contact lens. This contact lens is actually worn overnight, and then no correction, no glasses or contacts are worn during the daytime, which can be really, really convenient for some kids. I have some adults in this type of contact lens for the convenience. In this webinar, we're kind of talking about its benefit specific to myopia and myopia management, myopia control. So it does have a really good effect on that. These lenses were not created for that purpose. We just kind of stumbled upon the fact that it worked several years ago when people did retrospective research, and now many trials have been done that show that it does a good job slowing down that progression as well. So those are the 2 types of contact lenses. If a kid is having a progressive form of nearsightedness, and they're interested in contact lenses, to me, it makes perfect sense to just use one of these anyways, because they already want to do the contact lens options, and this can just be an extra benefit to the health of their eye. The last one on this slide is the eye drop that has to be compounded. The name of the medication is atropine. There's nobody that makes it commercially available right now. Same as most of the contact lenses that are available for this. There isn't an FDA indication for myopia control yet. You have to use the drop every day. It hasn't been studied with a part-time use in very much detail yet. And the cool thing about this is that if somebody was still having some progression more than we wanted in one of the contact lens options, we could add this to it. We could do a joint therapy. The eye drop, studies have said that it works really, really well. It's just difficult to obtain because of it needing to be compounded. But the studies really do back that it works out quite well for patients and for parents. So how do they work? That is a good question. We're still discovering more every day about how these contact lenses and the atropine eye drop seem to work for patients. The contact lenses has been studied better and is more well proven. It gives the prescription that is necessary to see clearly at the center of the retina, where we do our most detailed work, and then it gives a blur to the peripheral retina. This helps decrease a stimulus for eye growth, and that has been really well studied. So that portion of our understanding is really quite good. Atropine, the eye drop, may have some of the same type of effect. However, we believe it's more of an effect on a certain muscle inside the eye. It's called the ciliary body. Accommodation is what we use to look at distance and near and back again. That's what starts to go away in people who are over 40 and need bifocals to see clearly up close. So there's probably some component to that this atropine eye drop is helping. We just haven't been able to really prove that in a lab very well. and by we, I'm not I'm not doing any lab work on these, but I'm certainly paying attention to the research that's published regarding them. The average amount of slowing with any of these options is between 50 and 60%. Any less than that, and it seems to be not quite clinically significant. We look at around 30% to start being significant to us clinically. We do have some patients who get 100% slowing. They get a complete halting of their change, which is phenomenal. But we can't really tell people yet to expect to get that much slowing for their progression. So had our two examples from before, had they intervened and used a myopia control at that 50 to 60% slowing, our patient number 1, who previously ended up at a -5, is now a -3.25 when they're 15, which is really good. Patient number 2 still ends up with a high prescription, but it was an 8.25 if you remember before, and now with this intervention, it's around a -5. Most people who are a -5 are better candidates for LASIK than somebody who's a -8, so that's something to just keep in mind. That I would call these really successful numbers. And then probably the most relevant question to anyone who is listening with a child in their life who could benefit from this is, so which one to use? Genuinely, I think all of the options that I have talked about today are appropriate to use in certain patients. So I've used them all. It just depends on the results of kind of a routine eye exam can tell us which types of contact lenses might work for a patient, or if contacts aren't a great option, then using the eye drop and how successful a patient might be with that. So it really matters both the clinical, so like those numbers that we were looking at, and the health of their eye. That part matters in addition to lifestyle factors. And what I mean by that is it might be really a convenience for somebody to use Ortho-K and not have to wear glasses or contacts during the day. Or it might be that someone really doesn't want to be touching their eyes, and then an eye drop might be a better option for them. So I would say it just depends patient to patient, and I would just bring it up with your eye doctor next time you're in for an exam with your kid if you want to kind of talk about pursuing that route.